My training was from Birmingham in England, and then I moved to King's College Hospital in London, where I worked for about 4.5 years before joining a global hospital here in Chennai. I came to India because there is a lot of prevalence of liver disease in India, and transplantation services are limited when you compare it to the needs of the country. We hope that we can bring awareness both about transplantation, the need for transplantation, organ donation, which all help to minimize the impact of liver disease in our country. We have the necessary surgical skills, necessary anesthetic experience, the hepatology information required, but yet we are not covering all of the people who have liver disease, and we want people who might be having liver disease to get in touch with their doctors or with us directly, so that we can investigate about the needs of these patients or people. The important thing is there are steps that we can take with liver disease if it is caught at an early stage to prevent the need for transplantation, and that is what we want to do, that is what we hope to do. Especially even obesity, which is now becoming a problem in our country, can cause liver disease, can cause cirrhosis that needs transplantation in our country, and simple lifestyle changes can prevent this in that child. I mean, this child is a classic example of a sudden decompensation of liver disease that can happen in patients with cirrhosis, and when that happens, often we do not have much time to transplant that patient. And in this particular child, he is having problems because of water accumulation in his abdomen that is making it difficult for him to breathe, and his breathing was getting worse, his liver function was getting worse, and therefore we felt we had only maybe 36 to 48 hours before we could safely do a transplant. And we had only one donor in this child, which was the mother, because all the other family members were not suitable for donation. And even in this mother, the anatomy of her liver was not ideal. So we had to do this innovation, which hadn't been done before, to allow the transplantation to happen safely, keeping the safety of the donor and the recipient at a high level. Sure, I mean, there are many indications that suggest that somebody has got liver disease. Jaundice or yellowness of the skin or the eyes is the commonest thing that people come with. Itching is another common symptom. Weight loss, feeling very tired, excess of water accumulating in the abdomen. These are all early signs, or actually they are actually late signs. The earliest signs are only available on the blood tests, and therefore if there is any suspicion that there could be a liver problem, I suggest a very simple blood test, which is called a liver function test, and an ultrasound scan, which is painless, which is outside the body, will easily tell you what is the stage of liver disease, and it can catch diseases early when they haven't become cirrhotic and therefore not needing transplantation. I mean, liver disease actually thankfully progresses very slowly. For example, if you take obesity as one of the diseases that can cause cirrhosis that leads to transplantation, somebody has to become very obese, which is very fat, for approximately 5 to 6 years, and before permanent liver changes happen. So let us say he comes to us with a blood test that suggests that it is slightly abnormal. We can easily tell him the few steps that he needs to take, and his liver will go back to being a normal organ without the need for transplantation. And this is the beauty of the liver, and which is why we want to address it at an early stage. At the same time, unfortunately, there are patients whose liver disease has progressed, and their liver has reached a stage where even if they make those changes, it cannot come back to normal. That stage is called cirrhosis, and we want to make sure that even those patients have an option in transplantation, because transplantation is not like a cancer operation where, for example, you give them another year of life or 2 years. There are patients alive 25 years, 24 years after a transplant. And I have got a patient who I transplanted in London who was a water skiing instructor and now has gone back to being a water skiing instructor. So it gives you a quality of life that is almost equal to previously, before they have the liver disease, and that is why transplantation, I think, makes a difference. Most liver disease presents between 40 and 60 years of age. We would transplant anybody from a few weeks old to about 65 to 70. After 70, to do a transplant is quite difficult because the heart and the lungs and everything else has to tolerate such a big operation. The estimates from India suggest that about 19,000 to 20,000 people need a transplant every year. Currently in India, we only do something like 700 to 800 transplants. That means all those other thousands are needlessly suffering when they could have a transplant and get back to normal. I mean, the biggest challenge and the greatest tragedy in our country is that we have brainstem dead donors. In other words, cadaveric donors who can be utilized to save the lives of all these people with liver disease. Unfortunately, we are not utilizing that resource very well, and that is something that I want to tell people, that it is important to become organ donors so that their organs or your organs can be used to save the lives of somebody when it is of no use to the people who are dying. In every transplant that we do, it is 2 separate operations for living related transplants. Donor operation, there's about 3 surgeons, 2 anesthetists and about 3 nurses directly related. In the recipient surgery, similarly 3 to 4 surgeons, 2 anesthetists and about 3 nurses. After the transplant, it is the surgeons and the hepatologist who look after the immunosuppression for the patient and continuing aftercare. Radiologists are also an important part of this, and we have the expertise of Dr. Sridhar, who works in our hospital. Specific innovation required no scientific instruments, only experience. Now I have done over 30 to 35 split liver transplants or splitting of the liver, that is dividing the liver into 2 to use the liver for 2 people in King's College Hospital. That experience plus the experience of living related transplants of many donors has allowed me the experience to use the right hepatic vein for this innovation. So in terms of this direct innovation, no new equipment was used, but in transplantation we are constantly using newer medications, newer anesthetic machines, ventilators, and the dialysis machine called hemofiltration to improve the safety of our transplant. I mean, I hope, first of all, that we can do more awareness programs so that patients don't need to come to the stage of needing transplantation. However, if they are already at a stage where we cannot reverse the disease, then we would like people to come to us early so that we can transplant them when they are reasonably fit and when the results and outcomes are much better. The second thing is, we want donation rates to increase in our country to allow this transplantation without the use of a donor. And we only use living related transplants when we do not have a cadaveric donor.